I am so excited to have our distinguished Grand Round speaker joining us today, familiar and beloved to so many of you. So Carlos Del Rio is the Leon Haley Jr. Distinguished Professor of Medicine in the Division of Infectious Diseases at Emory and Professor of Global Health and Epidemiology at the Rollins School of Public Health. He is also our chair of the Department of Medicine and is the first graduate of our residency program to hold this position. So current residents, take note. Dr. Del Rio is a graduate of La Salle University in Mexico City, and he first came to Emory as a visiting medical student in 1982. So also students, and especially visiting medical students, please take note. He completed his internal medicine residency at Emory, his chief residency at Grady, and infectious diseases fellowship at Emory, and he joined our faculty in 1996. A global leader in HIV research and policy, Dr. Del Rio's research focuses on early diagnosis, access to care, and prevention of HIV infection. He has worked for over 2 decades with marginalized populations to improve clinical care and outcomes in the US and abroad, and has co-authored 30 book chapters and over 600 scientific papers. Dr. Del Rio is the chair of the PEPFAR Scientific Advisory Board, a member of the UN AIDS Scientific and Technical Advisory Committee, and an immediate past president of the IDSA. And among his many, many honors, he was elected to the National Academy of Medicine in 2013, and in 2020 served as International Secretary. In 2022, he was elected to the American Academy of Arts and Sciences. He's also received the Thomas Jefferson Award from Emory University, which is the highest award conferred by Emory to a faculty or staff member who has significantly enriched the intellectual and civic life of our community. He's also received the Otley Award from the government of Mexico for work that benefits communities of Mexican origin living in the US. In 2021, Dr. Del Rio was recognized by the Carnegie Corporation of New York as a great immigrant and great American, and also by Atlanta Mayor Keisha Bottoms with the Phoenix Award, the city of Atlanta's highest honor for his medical guidance and support during the COVID-19 pandemic. So now, if you all will humor me, in addition to these national and international accolades, Dr. Del Rio was also one of my faculty interviewers on my Emory interview day for residency. He also was the residency program director during my chief year, who shepherded us through a brutal ACGME site visit. He also is the singular person who, during my tenure as PD, helped me to get a foreign embassy signature on a visa delivered within 3 days for a resident stuck on vacation in a remote location so that they could return to work. And not once, but twice happened to be that person who helped me connect a resident with the exact job opportunity that they needed at exactly that time. He is just that kind of person. And during the height of the pandemic, while Dr. Del Rio was reassuring audiences internationally with his televised advice on masking, distancing, vaccination, and travel, he also quietly made sure that we here at Emory had everything we needed at home, including securing masks, test kits, and testing protocols for return to work so that we could safely return to work when everything was scarce. So I am of the opinion that we are so fortunate to have those pieces, the incredible wisdom, international reach and perspective, coupled with his genuine investment in our department and our people, and the issues that we're navigating day to day in our new leader and chair. And we are so fortunate to have him share his vision with us today. Dr. Del Rio, take it away.
Thank you, Karen, and thanks everybody. I am honored to be serving as chair of the department, and I am, this is really a dream come true and something that I'm looking forward to do. So let me tell you a little bit my outline for my talk today. I'm going to tell you a little bit about me and my career. I'm going to tell you about some challenges that I see in academic medicine, and finally give you a sort of 30,000 feet view of the Department of Medicine and my vision and what things I'm thinking about. And again, this is a work in progress. I've been chair for exactly 10 days. So, even though I've been thinking about this for a long time, I'm still gathering the data that I need. So let me tell you about my leadership journey first. In about, 7 years ago, so I wrote about this in an article that came out in a supplement about careers in infectious disease and JID. So a lot of what I'm going to say, you can go to this article and read it. It's a quick read about my life and what I've done. And also recently did a podcast And when I answer there, they ask me about what do I see, what is leadership for me? And for me, leadership is really the capacity to translate vision into reality. Uh, so a lot of what I like to do is think about that, right? What does it take to turn what our dreams are into reality? And I see that as what leadership is. So leadership has foundations, and for me, my foundations and my leadership style come from family, from values, from mentors, and from colleagues. And I'll tell you a little bit about that. So I'll tell you first about my family. I am from Mexico. My last name Del Rio, but really my family actually has been in Mexico for only a couple of generations. They actually spent a lot of their time in Cuba. They were in Cuba for many, many years until a distant relative, Alejandro Del Rio, who was a pharmacist. I have in my family, they're either physicians or pharmacists. This pharmacist was very involved in the War of Independence of Cuba from Spain, and he was a revolutionary, which you'll see as a theme. And he was arrested and he was executed in 1872. So his brother, who was a physician, Juan Francisco Del Rio, had to flee Cuba very quickly before he was arrested too, and went to Veracruz in the coast of Mexico. And that's where he had his family. And Narciso Del Rio was my great grandfather, and then my grandfather was Francisco Del Rio, they were both physicians. And then my father, Carlos Del Rio, you'll see, was actually not born in Mexico, was born and grew up in the United States in San Antonio. And the other part of my family comes from Ecuador. Uh, my mother and her family are from Ecuador, and she was in Mexico. Her father was working in Mexico as ambassador, and that's how she met my father and stayed in this country, in Mexico. So that's Juan Francisco Del Rio, who immigrated to Veracruz, and you can see here that he died in Veracruz and really settled in Mexico. He was the first member of my family to settle in Mexico around 1872 or so. But his son, Narciso Del Rio, was a physician, but he was also very interested in infectious disease. He was actually an epidemiologist, and he was very involved in the eradication of yellow fever from Veracruz. And when my father handed me this handwritten manuscript that he'd done in November, he submitted in November of 1892. I said, "Oh my God, how do I knew that I would have somebody interested in infectious disease as part of my relatives?" But this indeed was my great grandfather, and he was an infectious disease physician who was important in the eradication of yellow fever in Mexico. My grandfather was again he studied medicine and he was a physician, but he was also a revolutionary, very involved in the War of Revolution in Mexico. And after he trained as a surgeon in Europe, when he returned to Mexico, he was not allowed to return because he had been in the revolution. And then so he moved on to San Antonio and he settled in San Antonio and became a surgeon for many years in San Antonio and practiced there for many years until he always wanted to return to Mexico. So when he returned to Mexico, he became a diplomat and stopped being a physician and was a diplomat in multiple countries, and eventually died actually as an ambassador. So as I said, my father was born in San Antonio and grew up in San Antonio. And this is important in my life because my father was in San Antonio for the first 12 years of his life until his father went as an ambassador to Uruguay. But my dad, learned English before he learned Spanish. In fact, in his house, my dad would tell me about growing up in a Texas where there were signs of no blacks or Mexicans allowed in places. So his father actually, his patients introduced him as our Spanish doctor, never as our Mexican doctor. And my father and they were told not to speak Spanish because they will be recognized as part of that group. So my father actually taught me English from the moment I was born, and I grew up speaking English with him as sort of I say my maternal language was Spanish, but my paternal language was English. I was born in Mexico City 30 years after, and my parents by then had settled in Mexico. And I grew up in Mexico City with a brother and a sister that are younger than me, with a small detour to boarding school in Canada. At some point in time, my father said, "Your English needs to be improved," so he sent me to boarding school for high school, and so I can get better at English writing and other things. But I grew up in a house. My father was appointed a justice of the Supreme Court of Mexico in 1969. He was only 39 years old, the youngest person appointed as justice, and I was only 10 years old when he was appointed as justice of the Supreme Court. So I grew up in a house that the discussions were about law. The discussions, in fact, when I was in high school, people were very surprised that I wanted to go to medicine, into medical school, and not be a lawyer. Both my sister and my brother are lawyers. But I grew up in a house where the discussions were about justice, about equity, about law, and that was what we heard during lunch and during dinners. I did medical school in Mexico at Universidad La Salle, and I had this beard that some people confuse me, and nowadays I'll probably be not allowed into this country by ISIS, thinking I was maybe a terrorist. And when I proposed to my wife, Dr. Jeanette Warner, who's in pathology, to marry me, she said, "Fine, but take that beard away." So I did, and no longer do I have that beard. Uh, Came to Emory for postgraduate training as a medicine resident, and the reason I came to Emory was I had been here as a visiting medical student, but I wanted to be a cardiologist, and the fact that Jay Willis Hurst was the chair of the department really attracted me to come to Emory. But as you can see, things that happened in my life moved me from cardiology to infectious disease, and I did my fellowship here, and subsequently also achieved residency at Crawford Long Hospital, now known as Emory Midtown Hospital. But I had a wonderful residency class, and you can see some of my fellow residents here: Robert Strauss, Bill Ely, John Macer, John Merlino, Clyde Parton. Many of them have also developed careers at Emory. So I think that we had a terrific residency class that has continued to be together and to support each other throughout many, many years. When I was a PGY2, I was traded. Willis Hurst and Victor McCusick decided that they wanted to trade residents for a resident at Hopkins needed to come to live in Atlanta because she was going to marry one of our interns and have a baby. And Willis Hurst found nothing better than saying, well, Del Rio will go to Hopkins and Maura McGuire will come to Emory. So I was traded as a PGY2. It was unusual. It was scary. I had no way in that power decision to say no, but that changed my life. And it changed my life because at Hopkins, I learned, and you know, Willis Hurst and I continue being wonderful colleagues and friends, and I didn't had any regrets. In fact, I thank him for this because I met John Bartlett there, who was one of the leaders in infectious disease. And after my month working with John in the ID console service, and then having him as my attending on the medicine wards in the Osler service, I decided I no longer wanted to be a cardiologist. I wanted to be an infectious disease physician. So I show this picture of the Department of Medicine back in the 80s because you can see many of those people were influenced in my life. You know, Joe Hardison, Ken Walker, Jack Schulman. But you can see that everybody was white and everybody was male. There's a picture of all the division directors. And obviously something that has changed but needs to continue to change and to add diversity to who we are. And I see that as one of our goals. So as I said, you know, people that I consider very important to me going into infectious disease are David Stevens, John Bartlett, Sam Thompson, and David Rimblin. And primarily during my fellowship, I was working with David Stevens in his lab, and his lab was at the VA. And at the VA was David Rimblin, who was starting an HIV clinic. So I spent a lot of time going to clinic with him. But the working with David Stevens during my fellowship was critically important in me learning not only useful techniques, but really an appreciation for bench to bedside research, translational research. As I said, I started my residency with and did my residency under Willis Hurst. I did my chief residency and fellowship under Juha Koko, and then joined the faculty with Dr. Koko, and then was chief of medicine at Grady under Wayne Alexander. So I've been impacted for many of our chairs of the department. And David Stevens clearly has been very important in my life, not only as my mentor during fellowship, but somebody who has continued to be supportive and a mentor, and somebody that I not only have a lot of respect for, but I'm deeply appreciative for all his help and advice throughout my life. So at the end of my fellowship, I had been accepted to the CDC to be an EIS officer, but because of visa issues, I couldn't do that. So I went back to Mexico and went to work with a friend of mine who just had recently become an undersecretary of health, Dr. Jaime Sepulveda, who offered me a job, and I became the director of the National AIDS Program. I also worked closely with another good friend, Julio Frank, and was asked, had never in my life written a grant, but I met somebody called Fernando Zacharias, who was the director of the AIDS program for the Pan American Health Organization. And when there was opportunity to get a funding from Rockefeller to study HIV transmission in Latin America, Fernando called me and said, and Fernando had been an ID fellow here at Emory many years before me. And he said, you should write this grant. And I said, I've never written a grant in my life. And he said to me, well, I have a friend that is very good at grants. His name is Ken Holmes, and he was in Seattle. So very quickly, Fernando called King, and then I called King, and then I flew to Seattle to meet this guy that I had never met in my life, who then said he helped me write a grant. Spent 2 weeks with him. He helped me write this grant, and this grant was critically important for me. Then going on to working with CDC and meeting Jim Kern. So what else did I do in Mexico besides being director of the National AIDS Program? Well, I had pretty busy prior practice. I started an infection control program in my hospital that I worked at, which didn't have one. I taught pathophysiology in the medical school, and I also run a journal club with infectious disease fellows at the National Institute of Nutrition, a side where we are not now partners in our ACTG program. All these friends that were critical in my life, Jaime and Julio, have eventually returned to the U.S. and in various leadership roles. So what did I do when I returned to Emory? Well, I returned to Emory in 1997, and I returned mostly as a clinician. I was when I started working at Emory, I was on service 5 months out of the year and had 5 half days of clinic. But I wrote in 1997, really shortly after I had arrived, I was asked by David Stevens to write the CFAR grant, which became funded, unfortunately, and then had other grants. And as Karen said, I was also residency program director. At some point in time, I was also director of the Hope Clinic, chief of medicine at Grady, and you can see on and on other leadership roles. But all those leadership roles and what I've learned in them, really my only leadership training has been of the one I took at Harvard for a program for chiefs of clinical services back in 2007. But I did have a lot of lessons in leadership from early on in my career, and I want to tell you what those are. Number one is that age and experience matters. So you need to respect and seek the advice of people older and wiser than you. I think it's really important to work harder than anybody else, but I also think it's critical to create an environment where people succeed and prosper, and there's win-win solutions for things. So let me tell you about some of the lessons that I've learned in leadership. Number one is that opportunities are everywhere. So you should not be afraid to grab them. Number two is that change is part of the leadership role. And you don't need to wait for change to come to you. You need to be proactive and define the future. You need to continuously refresh your thinking and challenge the conventional wisdom. Just because somebody says this is always the way we've done it, it doesn't mean that it needs to be done that way. You need to have the best interest of others who work with you at all times. Because leadership is about making others better, not about making you better. And your responsibility as a leader is to inspire and unite people, because leadership is ultimately about serving the needs of people and an organization. And finally, I would say don't confuse leadership with status, power, or authority. Never underestimate the power of please and thank you. And finally, have fun. Don't take yourself too seriously. Laugh at what you do, learn from your mistakes, and have a good time. But I also think that the most important lesson in leadership is that nobody cares how much you know until they know how much you care. So really care about people, care about the institution, care about your work. So why do I attribute my success over life? I would say a couple things. Number one is this trust and support from others. I have had excellent mentors, and my advice is if you don't have a mentor, get one, because I continue to rely heavily on them. Number two is connectivities, networking, and collaboration with others. Find opportunities to meet others who are interesting. Take risks during life, opportunities, be creative, find your passion, and don't be afraid of failure. Persistence is really important. And if you fail, find why you failed and grow and learn from your mistakes. But I will also say that it's been really, really critical in my success working with my wife and having my wife as a collaborator, as a partner, and quite frankly, as a very good writer. And we've written 22 papers together and 1 book chapter together. So I'll tell you a little bit about my scientific journey. I've always been inquisitive, and I like asking the why questions. And I think that has been critical for me as an investigator. I think exposure to research as a fellow was critically important, and I encourage people in residency, especially in fellowship, to really get exposed to research. I think a very important lesson I got very early on from John McGowan was if you don't write it, it never happened. So if something is important, write it up. Well-researched case reports, I think, are incredibly valuable. Working in the clinical setting creates opportunities for investigation. Keep your eyes open and seek collaborators outside your area of expertise. Collaborate with people that don't necessarily know what you know, but otherwise that think differently than you do. And this is an example. When I was in residency, I was thinking about, is there a better way to diagnose pneumocystis? It was very hard to get, bronchoscopies done in patients. And we did a study looking at whether sputum was useful in the diagnosis of pneumocystis. And again, I was only a resident, my wife was only a resident, but we put together this protocol and did this study trying to show that you can diagnose pneumocystis by using induced sputum. I'll give you an idea, an example of a clinical observation, right? Just working on the SIS service, it was very clear to me that there were a variety of people living with HIV. There were those that didn't know they were infected. There were those that were engaged in care and regular care, came to clinic, did fine. But there was those that went in and out of care. There were intermittent care, and there were those that were not in care. And I learned very quickly that the reason why patients do not engage in care are incredibly complex and something that was an area of investigation. So I wrote this up and put together a paper, and then subsequently with other colleagues at Colorado, we wrote this paper about the spectrum of engagement and care, which essentially talks about what I said. We calculated in the U.S. how many number of people are infected, how many know their diagnosis, how many are linked to care, how many are retaining care, are in antiretroviral therapy. And back, in 2010, when we wrote this paper, we calculated that only 19% of the HIV-infected population in the United States was virally suppressed, something that the CDC, vehemently agreed it wasn't possible. But in fact, we had the data. But this paper, which has now been cited more than 1,500 times, was critically important in defining my research career because, in fact, many of the studies that I've done as part of my research program have been to improve this HIV care continuum. Have to be about, I did a rapid HIV testing study about how do we increase the number of people who know their HIV status. I did a couple of studies looking at how do we link people who newly diagnosed into care? How do we retain people in care? How do we get people in antiretroviral therapy and adhere so they're virally suppressed? And each one of these studies, either funded by CDC or NIH, many of them, two of them R01s, and many of them network studies, have been critically important in improving outcomes for people with HIV in the United States. For example, the rapid HIV testing study led to the CDC recommendation of opt-out testing in clinical settings. The ARTA study led to the ARTAS intervention, which is now a best practice by CDC. So each one of these studies has really not only led to papers and publications and presentations, but really actually influenced policy. And I saw Sonia Green as one of the people in the audience, and Sonia was an early collaborator with me actually in the ARTIS study. But because of the interest in the continuum of care, I was invited in my publications in that I was invited to be part of two panels of the National Academy of Sciences about monitoring HIV care in the United States. How do we know who's infected, who's suppressed, et cetera, and what recommendations do we have to improve that? But I think probably the most exciting part was in 2013 when I got a call from the White House saying that the president was signing an executive order to improve the HIV care continuum. And I was invited as somebody who had worked on this to actually be present at the time the executive order was being signed by the president. So really my research led all the way to a policy change and to an executive order that led to then funding from NIH to improve the HIV care continuum. So my good friend and president of the National Academy of Medicine, Victor Sao, says then that there's many degrees of impact, right? You could publish a paper, you can have a media coverage, you can get, be the basis of an RFP, what the research you've done. But the biggest impact is actually when you affect change, when you improve health outcomes, you get legislation enacted, you get policy change. And that, I think, is the kind of impact that our research needs to have. It really needs to push the envelope forward and needs to transform the life of others. Publishing papers is simply not enough. And I would say this HIV care continuum, then, talking with my colleague, Mo Ali, we said, this is not just limited to HIV. We can do the same thing for diabetes. And in fact, we published this paper in the Annals of Internal Medicine about how do we look at the care cascade for diabetes in the United States, and how can we improve the care for people with diabetes using the same principles that we use with HIV. But the other thing that this work has allowed me to see is really the impact of social behavioral factors, the impact of social determinants of health, the impact of substance use, the impact of things that go beyond just an infection. And in fact, my research has allowed me to see that HIV is not simply just a viral infection. It really is that center that brings mental illness, infectious disease, poverty, drugs into one center, right? And therefore, a lot of the work I've done is really trying to address HIV from looking at those other components about substance use, poverty, mental health, really looking at the entire spectrum and not simply thinking about it as a viral infection. So what I've learned about research over the last 30 years is that you have to be passionate about your work. You have to enjoy writing. You need to be prepared for rejection. I think papers and grants, I've had as many grants rejected as I've had funded, or probably even more. I think it's really important, I emphasize this, to select mentor who's successful and who wants to fight for you. But you also need to be sure that you help your mentor succeed. You never know when you're going to get his job. I'm getting David Stevens' job, so help him succeed, and then you may get his job. Please never do something that may be perceived as wrong. And take care of yourself. This is not just about work. This is really about taking care of yourself. And I think my biggest advice is that one of the biggest secrets to success is operating inside your strength zone, but outside of your comfort zone. So work on what you know best. For me, HIV, infectious disease, but go outside your comfort zone. Go into those areas like substance use and other areas that I had to learn how to work in as I was doing this work. And again, I put the example there of substance use, but working with Amita Kaloki when she was a second-year resident, she got me interested on intimate partner violence as one other area of impacting HIV. So let's move on to the Department of Medicine. The mission of the department and the vision of the department is to be a model for inclusive care, training, and development for a diverse patient population and workforce. And the values of the department are integrity, respect, trust, compassion, innovation, collaboration, inclusion, quality, accountability, and excellence. Think about those things every time you think about the department and how we're trying to advance our mission. And traditionally, we talked about the tripartite mission of the department, right? Patient care, we're here to provide excellent patient care. Education, we want to be leading in education of healthcare professionals. Research, we want to generate new biomedical knowledge. But I would challenge you that tripartite missions that has served academic departments very well up to now is no longer sufficient to help us solve the intractable drivers of poor health status in our population, such as the unfair and unjust health disparities that exist and are getting worse, health inequities, or difference in a population's social determinants of health. So as Dean Wong has said, we now need to have a quadripartite mission. And I would challenge you all to think about the department in a quadripartite mission. And that includes adding community to our mission. We need to think about how do we engage with communities to address the social determinants of health? How do we measure the impact of interventions we use? How do we use a deliberative structure and process to define those outcomes and to understand those outcomes? And what this is really operational research. Because if you look at this paper just published a couple of weeks ago in JAMA, showing us costs of mortality in the US, we're not doing well. And many of those causes are in our wheelhouse: diabetes, hypertension, kidney failure, heart failure, drug overdose, alcohol-induced causes. A lot of those things are in our wheelhouse, and we need to be leaders in those areas, and we need to be addressing those diseases, not simply describing them. So when I think about a department like ours, I'm always asking myself, how can we do things better? What will our learners need to know? How can we improve the diagnosis, treatment, and prevention of disease? And what do our patients need and want from us? So let's talk about the department. We're a big department. We have 10 divisions with 817 faculty, 592 staff, 208 residents, 169 fellows, 232 active research, and 44 postdoctorals. We are a big department. And we're spread across many locations, 50 plus locations, And this is a really big operation. So the first thing is many times you'll hear from me, and I'm going to call you, and I'm going to, one of my principles of leadership, it comes from this great book by Robert Massey, who wrote about Catherine the Great, among many other great books. I strongly recommend him as an author. In fact, his son was a liver transplant recipient at Emory, he has hemophilia and received a liver transplant for hepatitis C. And Catherine the Great used to say, "I like to praise and reward loudly and blame quietly." So let's be sure to celebrate the success of the department. Let's be sure to be always celebrating what we do. And for that, I invite you all Thursday to the award ceremony we're having, because it is a very important part of recognizing what we do, and we'll do it in a loud way. So the clinical operation, we have, as I said, 817 faculty. That's 428 clinical FTEs at Emory Healthcare and about 135.5 clinical FTEs at Grady. We have another close to 400 faculty that are work without compensation. These are clinical appointments and other appointments. Our residents, our fellows, and we're spread across 3 different healthcare systems. So, a lot of work is going to require reaching out and making sure that everybody feels included, that everybody feels like they're part of the department, of the mission of the department. We also need to realize that healthcare is moving beyond the traditional patient healthcare professional interaction. We need to think about new models of healthcare delivery. We need to create clinical programs that are more decentralized, more adaptable and responsive to patient preference. We have to get involved in practice innovation, in integration of care delivery into medical education. How do we do medical education in this different environment? We need to reimage the care process and the team in order to handle the increasing amount of clinical data. How do we incorporate digital technologies into our practice? A lot of questions, a lot of things in which we could be leaders in healthcare if we so desire. How about our research mission? Well, critically important. We have a big research operation, close to 200 million in research awards in FY23, with more than 1,200 publications, more than 200 principal investigators. So a big clinical operation, right? A big research operation. And our Department of Medicine research funding has been growing up. Very good. We're all very happy about that. Our publication record is clearly fantastic. You can see, here are the publications and the number of faculty contributing to them. But when you get down to the specifics, the Department of Medicine has 45 PIs with active R01s. And in fact, several have multiple R01s. And we only have 16 active K awards, of which 6 are in infectious disease, 3 in pulmonary, 2 in endocrine, 2 in nephrology, and 1 each in digestive diseases, general medicine, and geriatrics. And when you put that into a table like this, and I'll make it a lot simpler, I compare to you with other institutions. You can see here that if you look at the R01 count, we're way behind our peers. You look at Michigan, Duke, Pittsburgh, Penn, Vanderbilt, they have a lot more R01s than we do. So the number of investigators having R01s is pretty low for the size of the department and for the peer institutions we're competing with and we're competing against. Furthermore, if you look at this, you can see again the R01 data. Here's Michigan, Duke, Pitt, Penn, and Emory, and you can see the R01 funding we're the lowest of those group of institutions. And if you look at the K funding, we're pretty close to the low. I mean, Duke has about the same number of K awards that we do, but you could look at Penn with $12 million, and all the others are way higher than us. And that's because we have a smaller number of active R01s and K awards than most of our peers. So in order to compete with them, we're going to have to basically grow the number of awards that we have. And as I said, our trajectory is good, but it's really based on primarily a couple of divisions. And you can see here, both in proposals and in actual funding, infectious disease leading the pack with about $60 million. But you can see that after rheumatology with 15 million, all other divisions are below 10 million. So if we can get 2 or 3 of our divisions above 10 million, we would not be number 18, but we would be in in the 10 to 12 range if we did that. So there are 2 initiatives that Beba Lama is working on that I think are really important and I think have to do with research. Number 1 is support our investigators. We're clearly understand that we have trouble doing research at Emory. We have a lot of barriers. And we want to work to improve, want to work with investigators to implement strategies to improve support and resources so people can actually do their research and be successful doing research. But number two, we need to grow our investigators, and we'll do it from the outside by recruiting people, but we also need to do it from the inside. We have to develop, because I can tell you from having been in the ID division, a lot of the success of the ID division is by developing our fellows and turning them into investigators, care awardees, and then subsequent R1 awardees. So we have to work from within to develop our next generation of investigators. And we also need to think about those new areas of research that I've been mentioning. Health disparities. People talk about studying the exposome. What are the exposure? What are the external factors that drive disease? Implementation science. I would love to build a large implementation science program in collaboration with colleagues at the School of Public Health. Substance use, artificial intelligence, machine learning, immunotherapies, telemedicine and digital health, phage therapy. I mean, these are some of the areas that I've thought about that we can grow to grow our base of investigators, but also have our impact go beyond our research. Let's move on to talk a little bit about education. As I said, the Department of Medicine has a lot of faculty that are either course directors or clerkship directors in multiple courses in the medical school. And clerkship-wise, we have the third-year medical clerkship, the fourth-year medicine sub-I, the ICU clerkship. We have many residency programs. We have a large residency program with 208 residents, have multiple fellowship programs, many faculty who work in the graduate school, faculty that are involved in the teaching in the PA program and other programs. So our faculty does a lot of education. And I also see that there's a lot of challenges to spend time doing education. There's clinical pressure, there's other productivity pressures that make it harder and harder to be involved in education. So how do we work on that? How do we rethink how we're going to do that in a more effective way? How are we going to support our clinician educators? Because there are a lot of challenges, right? Clinical productivity and increasing market share has educational consequences. It limits faculty bandwidth, and then we see faculty and clinics relocated to away from primary training sites. High levels of student debt undoubtedly are influencing career choices. I think funding for GME has remained flat and continues to remain flat, and I don't see GME slots increasing. And there are new external and internal challenges that have implications for training, recruitment, accreditation that I think we need to be on top of. But I think that preserving the integrity of our educational programs is going to require really maintenance of high standards of education, careful attention to the learning experience, and adequate mentorship for research and career development. And I think a lot of my focus around education is going to be really about how do we get those things done over the next couple of years. So are there challenges in academic medicine where we practice? Undoubtedly there are. I think today staying afloat successfully is hard, right? With rising personnel costs, with student debt, with decreasing reimbursement, with a very tough funding environment. So how do we define success? How do we say somebody's successful? Are we using the same metrics in the past, or are we going to think differently? We have typically thought about success as, you got your own R01, you're a first author or last author on a paper. But with team science, with big data, with big research, that's not how you measure success. We need to think about different ways of measuring success. How do we work on decreasing the burden of the EMR? What are we doing about the widening health disparities in our country? How can we do better in coordination of care? And how do we deal with provider training and staff burnout? Those to me are some of the major challenges that we're dealing with. But there's always opportunities, right? On-demand learning and care. How can we use disruptive technologies to do what we need to do? How can we think about a flipped clinic model that's more community-centered, more patient-centered, communication-centered? How can we use big data to solve clinical problems? How do we look at data and assess that in behaviors and looking at what we do? And how do we do rapid cycles of implementation and improving quality and looking at feedback? All this, I think, are great opportunities to improve patient care, but also create new knowledge and new discovery. So just one word about finances. I love this phrase about the margin should be by no means. The margins are a means to achieve our mission, but should not be the mission itself. And I think when we think about what we're doing in our budgets, we have to think about what we're doing first and how do we achieve the mission. And I say so because if you look at our Emory Clinic operating budget, you can see that our total revenue is $268 million, and our total expenses are about $346 million. So yes, we have an operating deficit of about close to 80 million, because you cannot be, you cannot be in a positive area. Very few people are positive in academic medicine. So academic medicine, a lot of it is subsidized, but we're trying to decrease that subsidization. That's what we need to work on. And you can see from the School of Medicine perspective, again, that's what our budgets are. And then they cover a few things, but they don't cover a lot of what gets covered is really from the healthcare system, both from Grady and Emory, primarily from Emory Healthcare. So inclusion, diversity, equity, and access are also important areas. I showed this table that the other day I saw at a presentation, and I added our numbers. This table went through U.S. Medical School faculty, but I added Emory School of Medicine faculty, and I added Department of Medicine faculty. And you can see that, we're doing pretty good in some areas. I mean, I think we are doing better than other places, including the School of Medicine in some areas, but we're still pretty low, for example, at Emory in general, and this Department of Medicine as well, in the number of Hispanic faculty. So we need a lot more diversity, and we need a lot more diversity in leadership. So I'll work closely with our DEI leaders that I really value, to work on improving diversity, improving equity, inclusion in our department. And again, diversity is much more than racial and ethnic diversity. There are many other areas of diversity, but we need to value diversity and continue to make it a core principle of what we do in our department. So in summary, as I thought about this, these are my priorities as I start as chair. Number one is, continue to think about well-being. I think recruitment and retention of outstanding faculty is critically important. We have to elevate our educational programs. As I said, we need to continue focusing on inclusion, diversity, equity, and access. Philanthropy is an area that I plan to work a lot on. I think we need to continue to have financial strength and work on that. We need to do better collaborating with our clinical partners to not only provide care there, but actually influence care, define care, provide new models of care. And I want to make a priority communication. I think it's really, really important to have two-way communication in which I listen to you and you listen to me, and you get the information you need, and you feel like you're part of a department, and you feel listened to, and you feel also engaged and communicated. So I've been in faculty for 28 years, and why I say take care of yourself is when I arrived at Emory in 1996, these were my kids. They were 8 and 5. And you can see them 28 years later. They're married. Each one has 2 kids. And I've done this while at a faculty at Emory. Emory has been my home, but it also has been the place where I grew a family, and a large family. And for that, I'm incredibly thankful. So Karen said at the beginning that I wanted feedback, and indeed I do. I want to hear from you. We need to work together so we can elevate the Department of Medicine to new heights. So please feel free to reach out to me by email, other places, suggest with ideas, suggestions, thoughts. But we all going to work together to increase and to improve the Department of Medicine, because this is a continuous role that we need to have. If this is a good department, it benefits everyone, and we all feel better working there. And I want to acknowledge and want to thank Dr. Beba Lama, Dr. Wendy Armstrong, and John Souter, who facilitated some of the slides that I presented today. And with that, Karen, I will end my talk and then open for some questions and discussion, because I think I wanted to make this given plenty of time for questions.
Absolutely. Thank you, Carlos. Thank you for your excellent overview and introduction and presentation. And on the theme of communication, we have 15 minutes to have an open discussion with the chair and 230 faculty and staff across the Department of Medicine and other Emory affiliated departments. So I'd love for you all to drop additional questions in the chat. Susan Ray had a question for you when you were reviewing some of the.
So Susan asked about, yeah, in most other places, Department of Medicine includes HEMONC. HEMONC in our department in a school is a separate department. HEMONC is included in our NIH rankings, but otherwise it tends to be independent. And I think, I'm actually meeting next week with the chair of the Department of Oncology, because we have to find ways to collaborate closely. We have, for example, for education, in my mind, when I think about places like the Brigham, for example, many residents go to the Brigham because they want to either do hem-onc or do cardiology. It's critically important to have a strong collaboration with hem-onc if we want to recruit outstanding residents. Otherwise, they're not going to come here. So it's in the benefit of all of us that we do that.
Thank you. I think I saw some cameras turning on, so I'm not sure. Oh, sorry. There's a question in the chat, but others with cameras turning on, did you want to unmute and ask a question?
So any specific actions envisioned to improve R01 success rate? Well, I think that, again, I have found that having working with people that help you review your grants, that help you do mock study sections, that help you look at your specific aims, that do internal reviews are incredibly helpful as you go to submit a grant, because quite frankly, grants get a lot better if they're so, but we obviously, to do that, you need to have your grant ready weeks in advance before its due date. But I think facilitating, making grant writing courses available and writers available, but also doing ways, facilitating ways for people to have their grants reviewed internally. I think it's going to be really important.
And then you see Joanna Bontel's question there, our Chief of Medicine at Grady. Any specific initiatives that you'll be tackling early?
Well, I mean, my number one initiative right now, is we're deeply involved in recruiting a new chair, a new division director of digestive diseases. And I think, putting
Infectious
together
disease.
a team in place. I've talked
Infectious
to,
diseases, right, Shanti?
yes,
I
and
think for the renal division,
nephrology,
yes,
nephrology, and we're actively recruiting a division director of renal of nephrology, and we have to also we have an interim division director of ID, and I'm trying to finalize that. So Wendy stays as our division director, but I think those are my major issues right now. But I also say that, and I talked to this a little bit with you, I think, Karen, is I also want to have a couple of retreats looking at our educational programs and looking at our undergraduate medical education and our graduate medical education, and what can we do and how do we improve that in the department. So looking at the clinician educator role, I think, is really important. Uh, and uh, and uh, and really then thinking about the collaboration and the interactions with the health system. I think that's the other component. We have right now, specifically as it relates to Grady, we're getting engaged in the renegotiation of the contract with Grady, and I'm part of the negotiation team, so I'm going to spend a fair amount of time in there.
Shanti, I'm going to send the mic over to you.
So thank you, Carlos, for your vision and your for the future. Very, very exciting. I wanted to ask about the K grants that you mentioned and how important that is in terms of feeding towards our grants. Along those lines, I was thinking, what do you think about the T32 programs that can help, protect time for the during fellowship and then really lead on into the K grants, and whether we can think of creative ways to encourage T32 programs within different divisions of our department.
I mean, I would agree, and I would say, I think recently, I think Greg Martin at the Division of Pulmonary put together a T32 that I don't think it got funded, but it was a really good idea about how do we get this integrated approach to training. And because again, we need to think about interdisciplinary training. We need to think more about how do we develop the next generation of investigators that are not just, sort of disease specific, right?
Yes, thank you.
And then next hand I see is Briggy James.
Hi, I work for an HIV program, and I just want to know the vision for community outreach that Emory is seen as a leader in helping people who are living with HIV.
Well, for sure. I mean, I think the working with community is something that I've always done in the area of HIV. I think at the end of the day, I think it's one place where the community impact and input into a programs has been critically important is in HIV. So I think it's a lot about going out there, right? You don't wait for the community to come to you. You go to the community and you find out what they need and how you work with them and how do you design programs that benefit them. So a lot of it is really going out to the community and thinking, how do we work with you? And one of the initiatives that, together with my colleague Amita Kaloki, we've been working for several years now, and hopefully we'll get it done soon, is we're working on an HIV mobile clinic going out to community and working with them. So I think those are the kinds of initiatives that I'm thinking we need to do.
And Carlos, I'm going to turn your attention back to two questions in the chat that are nice in terms of covering, sort of spanning a couple of the issues that you talked about. Jessica Fairley notes, faculty don't have time to write grants when they have a heavy clinical load. Any thoughts on how to address this?
Yeah, no, it's true. We're going to have to figure out how to address it. I don't have the answer right now, but I know that's exactly part of the issue. And as I said, the clinical burden, the clinical load is a burden to doing our missions of education and research. And I think, how do you balance that? I think it's if I had the secret sauce, I would be selling it in bottles, right? Because it's not and making a lot of money. I think we need to figure out how we're going to do that, and how do we provide the protected time for people. How do we ensure that people are going to be successful? And I think it's going to be, a lot of it is going to be about, you know, what do you want to do and how do we get it done, and how do we get the funding to do that and make it in a successful way. And it's not simple, but you know, let's try to figure out creative ways of doing it. I got some ideas, but not fully developed, quite frankly.
Okay, and then I'm going to transition us over to Lee Partington's question, and she has been really instrumental in supporting some of the writing efforts of our general medicine faculty. So again, all of this kind of ties together. But her question is, Department of Medicine staff are critical to the success of Department of Medicine faculty. Are there any new staff initiatives in the works?
I need to think about, you know, I mean, I agree 100% with Lee. The staff are critically important to the success of the department. We cannot have successful faculty and trainees if we don't have, you know, the support and the work of staff. So I think we need to work together and think about, to me, the most important thing with staff is providing them with career paths and ways in which they feel part of the mission and integrate into the mission. And those are, I think, one of the things that I want to work with the administrators to see can we do that in a more successful way.
Thank you. And Viva, a comment or a question? Oh, you're on mute.
I wanted to thank Carlos for this. Carlos, it was lovely hearing about your background, really. And seeing that ID paper by your grandfather and then what you have done in the field, it's amazing. I think we touched on a lot of points which you have to, with such a big department, so many multiple missions which we have. I wanted you to comment a little bit on philanthropy, because that's an area which touches on a lot of these things. We are talking about finding more time for our faculty. We can do that by some endowments, some junior endowments to help us to protect some time for them. We want to start new research programs. We want to, so if you, can you please give us your vision for philanthropy and how developing maybe more professorships or endowments, or that'll be good. Great.
Well, no, I think you touch on what I think is one of the keys to success. I think is going to be philanthropy, and I think working with our development people is going to be critically important. How do we do that in a way that not only we bring, you know, more professorships, but bring other programs. And right now, for example, in the Division of General Medicine, Dave Roberts is working with what hopefully will be a fairly large gift. But I think that I agree. There's a lot of money in our city, and we have to tap into philanthropy. I think that is something that we have not done as successfully as we should. And I'm good at that. So I'm good at asking people for money. So I will continue to do that because it's an area that I like working on.
And then we should also add, there is a campaign that has just started by some of your previous residency colleagues in honor of your assumption of the chair position. That's a fundraising opportunity as well. And so
yeah, to support the residency program. So, you know, it was three of my colleagues who were, you know, interns and residents with me put this together and said, we want to do this. And I think it's great.
Great. And then Emily Cartwright, thank you for this presentation and sharing your vision and priorities. How can the Atlanta VA be incorporated into the Department of Medicine mission, especially in the areas of education, training, and research?
No, I think the VA is a great resource, and I think it's a great clinical and educational and research site. We need to incorporate it better. I think we're a better department because we have a VA, but we need to figure out how do we make the VA be a true partner in this. I think we have the leadership of the VA is better than it's ever been, And in my role as in the dean's office, I've connected with them and I know them and I work with them. So I hope to continue doing that and collaborating with them going forward.
Great. All right. Any remaining questions? And as you heard, the chair wants to hear from you.
So yeah, spam my inbox, please.
Wonderful. Well, Carlos, thank you so much for kicking
Okay,
us
guys.
off for our Grand Rounds season. And for everyone out there who's going to be applying for CME credit, the CME tracker number is 18851. I'm going to put it back in the chat again. All right. Thanks, everyone. Have a great day.